Okay, so as we get started today, I want to recognize to you that I understand that you already might have a strong opinion on healthcare policy. You may not have much of an opinion at all, or maybe you have a strong opinion. And so I respect that. But I do hope today that you will keep an open mind because you might learn something new. As a closing thought as well to our introduction today, let me emphasize that we tried very hard to represent both sides through the questions that I planned, the videos that we picked out, the committee of students and staff. But as in all things in life, we're not perfect. And so if we miss anything major in your opinion, we'd love to get your feedback. Our mission is to bring all the important issues up, not just right ones or left ones, but all of them. So with that said, if I've left out anything major today in your opinion, feel free to reach out to me and Seminoles Decide. We have a Facebook page. That's a great place to do that at. So our first panelist is Dr. Raymond Bellamy. He received his medical degree from the University of California at San Francisco. He was a member of the United States Navy Medical Corps. He's been practicing orthopedic surgery in Tallahassee since 1974. Dr. Bellamy has always been active in the public policy arena and currently serves as the chair of the Capital City Chapter of Physicians for National Health Program. Please join me in welcoming Dr. Ray Bellamy. There's a bottle of water. You get thirsty.
Thank you.
Yeah. Okay, our next panelist is Dr. Les Beisch. He's the Associate Dean for Health Studies at the FSU Medical School. He previously served as Deputy Secretary of the Florida Department of Health, and he was the Commissioner of Health for the state of Oklahoma. He received his medical degree from Georgetown School of Medicine in 1980 and went on to earn his law degree from Harvard Law School. Please welcome Les Beisch.
Les wants to know, do Gators decide?
I hope not. This isn't kind of an extemporaneous comment, but just so you know, the difference in Florida in the year 2000 between Al Gore and George Bush was 537 votes. So not only could Gators decide, but one class of Gators could decide.
They're well informed.
So our last panelist is Dr. William Weissert. He's a professor of political science, my department, and is the director of FSU's Masters in Public Health program. He's achieved tenure at 3 institutions and is highly sought after for policy consulting in healthcare policy by both government agencies and private organizations. He holds a PhD from the Claremont Graduate School in Claremont, California. Please welcome William Weissert. So many political scholars think that America is more politically divided than ever, and perhaps we are, but it's by my assessment that in terms of healthcare policy this election, the differences between the two candidates couldn't be clearer. And we have 2 clips to kind of get started and to frame just the difference between Mitt Romney and Barack Obama that is there. So let's check those out.
The president has declared that the debate over government-controlled health care is over. That will come as news to the millions of Americans who will elect Mitt Romney so we can repeal Obamacare.
I believe it was the right thing to do, because that's part of making sure a middle class is thriving in this country, that they don't have to fear that when somebody in their family gets sick, that somehow they're going to lose everything they've worked for all those years. I make no apologies for it. It was the right thing to do, and we're going to keep moving forward. That's why I'm running for a 2nd term as President of the United States.
So my first question for the panelists is going to be, you guys going to come back up? I think it's important in understanding the current debate to know the context that we exist in terms of healthcare in America. So I think what I would love to hear you guys comment on is what have we done well and what are we struggling with in America? What's gotten us to this point? Dr. Weissert, why don't we start with you?
Well, what we've done well is hard to put your finger on. I'm going to leave that to Dr. Beisch. I would say what we've got to worry about is what we've done badly, and we've done a lot of things quite badly. First of all, I think on Obama's agenda, when he passed the Affordable Care Act is that we have 50 million people who don't have insurance. That results in 27 or 30,000 deaths a year. That's a phenomenal situation given for such a rich country, and the fact that we pay 2.5 times as much for care as anybody else in the world. That's 2.5 times as much as the industrialized nation. We pay magnitudes of difference with other smaller countries. Our quality of care leaves a lot to be desired. We kill, the Institute of Medicine some time ago estimated between 50,000 and 100,000 people a year in the hospital. They don't die of their disease, they get killed there. If you go to the hospital, you have about a 1 in 4 chance of coming out with an injury from the hospital. As a matter of fact, there's a guy at Harvard, Lucian Leap, you may know him, a very good guy, who estimates that you don't want to do bungee jumping because your odds of death are 1 in 100. You don't want to do mountain climbing because your odds of death are 1 in 1,000, the same as going to the hospital. So you could choose, shall I climb a mountain or go to the hospital, and you're just as likely to be killed in one as the other. If you sleep next to a nuclear power plant for 10 years, your odds are about 1 in 2.5 million of being killed. So the risk in our healthcare system is serious. One of my favorite indications that we have a lot of room to improve in our healthcare system is that we deliver different care to the same patients in different cities. And so in Tallahassee, the average Medicare patient, people use Medicare data because the population is so big and we have a lot of data on it. The average Medicare patient here costs about $8,500 a year. In Miami, similar patients cost $15,000 a year. No better outcomes. In fact, the patients are less satisfied in Miami than here. They see their doctors about twice as often, and they wait longer. And even their physicians are more dissatisfied than here. The researchers at Dartmouth University have looked at this for 30 years and ruled out all of the obvious explanations, sicker patients, meaner patients, all those things, and it comes down to physician style of practice. It's just the way the physicians choose to practice given the environment they're in. And also supply sensitive services. More equipment around means more equipment gets used. Well, I want to quit. There are lots more problems I could talk about, but I'm going to leave it to others to do the same thing.
Well, if I can just pick up where Bill left off. First of all, let me ask you, have any of you ever seen a program called Newsroom? Have you watched that? In the very first episode of Newsroom, someone asked a question to the major protagonist, in a sentence or less, what makes America the greatest country on earth? To which he first responds, America's not the name of a country, this is the United States. Number 2 is, we're not the greatest country on earth. We're number 1 in incarcerations of our population, and goes on a long list. And there is no indicator that you can point to that's a health-related indicator to suggest that we're doing things right as it relates to health. And I challenge you to come up with a good number or a metric that says the U.S. is number 1 in health care in any way, unless it relates to cost. And people talk about a 3-legged stool with respect to health, and Bill really centered on those things. So you talk about, first of all, you talk about access. So does everybody have access to health care? Yeah, I bet many of you traveled somewhere this summer outside the United States. Did any of you travel outside the U.S.? Okay. Did you go to a country that everybody had health insurance? Because it's hard to find a country where that's not the case, actually. So if you didn't, what country did you go to? Because I saw a head nod. Where did you go?
Ecuador.
Ecuador? And they don't have health care for everyone? Or they have the same poor health care for everyone? Because Peru has health care for everyone. No one gets it in the same inaccessible way. And that's true for other countries. Most developed nations, of which they all have health insurance for everyone, we don't. So we have over 50 million people that are excluded. So if you look at that 3-legged stool and you say, well, access, not good there. Bill mentioned quality. The quality of our care is very uneven. and it's disappointingly so. And that's been an area, for over the last decade that I think we're finally starting to pay the type of attention to that's needed. But the overall quality of care, as Bill suggests, somewhere around 98,000-ish people every year lose their lives as a consequence of interacting with the healthcare system. And it can be for a variety of reasons. The most recent episode was several people died who received contaminated type of steroid injection. And I actually knew one of those people. Very tragic situation. And finally, then you look at cost. And we pay a lot for that cost. It's 17.5% on its way to 18% of all the goods and services produced in our country. And that sounds like a lot for a couple of reasons. It is a lot. It's the biggest industry in the United States that no one knows about. Secondly, every dollar we're spending on healthcare is a dollar that we're not spending on something else that might be important. It might be your education. It might be having better jobs in our country, in addition to better schools, safer environment, cleaner environment. So there's an opportunity cost associated with that. But just going back to the three legs of that stool, you'd need a very short stool for where we are in this country. And so if I had to summarize what are the good things that we're doing in healthcare, we're starting to have a conversation about it. The Affordable Care Act was the first effort since 1965 to have a national policy as opposed to a default on what healthcare might look like for our nation. And that debate should include things like prevention. And that's where all of you come in, and I'll stop at that point, is we demand certain things from a healthcare system, but they're the wrong things. That we have some individual responsibility as members of a community, as residents and citizens, to actually improve our own health and to work towards being in a healthier place. And we pay scant attention to that as a country.
All right, so
well,
without
let
a
me
doubt.
just add one more thing. Ray,
Sure.
I'm surprised you didn't talk about insurance. You want to do that?
Talk about...
Well, if you're making a list of things that are wrong with our system, you can't leave out the fact that our insurance industry is abusive and doesn't cover people. It does things like, this is a word that had to be invented for insurance. I think it was invented in hell. It's rescission. It means you pay for year after year after year for your health insurance, then you get sick, they go back and look at your application 20 years ago and say, you didn't tell us that when you were a freshman you had acne. And when you had acne, you were treated with acetone. That's not right, aspartame. And therefore, we're not going to cover your breast cancer. Now that you have breast cancer, now we're interested in what you had back on your application. We're not going to cover you. That's called a rescission. It's completely legal. It's made illegal by the ACA, thank goodness. Another abusive tactic of our insurance industry, it's not because the insurance industry is bad, it's because of the way it's structured, where if you're the nice guy in the insurance industry, you get all the sick people and you go bankrupt. And we need to fix that. And so there are some other provisions that means every insurance company looks for the least sick people. And if you're sick, they don't want you. There are limits on how much the insurance company will spend in a year on you and in a lifetime. And in our system, $1 million is not a lot of dough. You can run that up pretty fast.
Dr. Weiser, your comments actually, I think, would be better suited after our next video, the ACA. So I'm going to respectfully ask us to move forward just a little bit. So we've talked. All three of you have already mentioned. Well, Dr. Bellamy hasn't mentioned anything yet, but the two of you have mentioned the Affordable Care Act, and it's by far the most controversial healthcare policy of this election, and might be one of the most controversial issues of the election. We certainly saw that last night in the debate. So to sort of kick off our discussion about the Affordable Care Act, I have a video that I want to show the audience that's about 3.5 minutes long by CNN, and it attempts to explain the basics of the Affordable Care Act, and we'll go from there.
In 2009, when this law was being debated, pretty much everyone agreed that this country had a problem. There were way too many uninsured people. By some counts, 49 million uninsured Americans. So everyone agreed something had to be done, but everyone disagreed about what had to be done. What Obama came up with is a rule that says everyone has to have insurance, and you can get it through your employer, you can get it through the private market, you can get it in a variety of ways, but everyone has to have insurance. When people don't have insurance, well, they're really in a terrible pickle when they get sick. I mean, imagine you don't have insurance and God forbid you get hit by a car or you get cancer. How are you going to pay for that? Not only are you in trouble, but the rest of us are in trouble, because if you don't have insurance and you get hit by a car, the rest of us are paying for you to get care. It comes out of our tax money, it comes out of our insurance premiums. We all end up taking care of the uninsured. The health care plan was passed 2 years ago, and it's implemented in a series of stages. Some things happen very quickly, and other parts of it don't happen for a couple of years. Healthcare reform has already made it illegal for insurance companies to say no to a child with a pre-existing condition. Before healthcare reform, insurance companies would often tell children with pre-existing conditions, no, sorry, we don't want to insure you, because it's expensive to insure someone who already has a serious condition. Insurance companies have already been told no more lifetime limits on benefits. What used to happen is that insurance companies would say, you have, let's say, $5 million of benefits, and that's it. And when you hit that $5 million cap, you can't have any more care. Healthcare reform law said you can't do that anymore. There are no more lifetime limits. Now, most people never even meet this cap, but if you've got a serious illness, you can actually meet a $5 million cap relatively easily. Healthcare reform also allows children to stay on their parents' insurance until they're 26. One of the things that will happen in the future because of healthcare reform is insurance companies will have to accept adults with pre-existing conditions. They can't say no to you just because, let's say, you have asthma or you have cancer or heart disease. So in 2016, you'll have to buy healthcare insurance. It'll cost about $5,000 for an individual, $12,500 for a family. And this is the most basic insurance. You can also spend more money and get, fancier insurance that gives you more coverage. So if you don't buy health insurance, you are going to have to pay a fine. That fine is approximately $350 for a child and $700 for an adult. So for a family of 4, that could be about $2,000. So this law says everyone has to have health insurance, and let's face it, we all know that health insurance is expensive. So what the law does is, one, it allows more people to receive Medicaid, which is the federal program for health care insurance for people who can't afford it. And if you don't qualify for Medicaid, you can still get subsidies from the government to help you pay for insurance.
How many of you could you raise your hands if you're covered under your parents' policy because you're under 26? That's huge. And there's some really good features in this. That is one. The no pre-existing conditions thing is one. The preventive services are huge, and they're free, including contraceptive services. And I think it's been shown that $1 in contraceptive services or family planning saves taxpayers $3.74. And of course the expansion of Medicaid, which will cover a lot of those uninsured. Now currently we've got maybe 49 million uninsured. It was 50 million before this age 26 thing came in. It's now 49 million, but those numbers will be reduced to about 27 million, it's estimated. So under the ACA reforms. So these are big, really good changes that are welcome. Is that?
Yeah.
Okay.
Dr. Beisch, what are some of the most striking parts of the ACA in your opinion?
Well, I think the ACA does a lot to place the U.S. where other countries are in terms of moving towards a universal access system. There are other ways to do that, and I'm sure we'll talk about them before this afternoon is out. but it's the first significant expansion since the development of Medicare and Medicaid and children's health insurance to really begin to cover most of the population. The Medicaid expansion is huge. The opportunity to have exchanges and an open insurance market, I think, is huge. And for our elder citizens who receive Medicare, it's the closing of the donut hole that causes them to pay extensively out of pocket for medications. That's going to be closed in this. And I think some of the provisions you heard from from CNN, the removal of the lifetime caps and also the annual caps on insurance, I think are going to make a huge difference.
Dr. Weiser, can you discuss specifically this idea of the Physicians Advisory Board that sets new standards of what physicians can do so that there's not unnecessary procedures?
Dr. Beisch mentioned that we're moving closer to other countries in universal access. We are also, for the first time in the ACA, moving closer to the way that all these other industrialized countries that hold their costs down, the way they do it. They do it with a board. And that board usually is made up of physicians and economists and policy analysts and others. So in this ACA, we have the Independent Payment Advisory Board. Their basic mission is to say, if you can't show me the research evidence that this is going to work, we're not going to pay for it. And that's the essence of their mission. Over time, they will, and they also will advise on physician payment and hospital payment and other things. Now, we've had versions of this in the past, and they've been helpful, but we still pay our physicians more than any other country, about half again as much. And we also have way too many specialists relative to primary care docs. Every other country that's rendering better care, extending life longer, keeping costs down, everyone relies heavily on primary care. We rely very heavily on specialist care. And so the ACA tries to improve access to primary care by increasing somewhat the pay that they get and trying to encourage training of nurses and other people to extend physician practice.
This principle of having a comparative effectiveness panel is that inflames the right who are saying this is a government takeover of healthcare, and yet it has to be approved by Congress or the recommendations of that panel don't take effect. And I agree with Bill, and I think Les, that we must have more centralized control to hold down costs, because to me, the two biggest problems with our healthcare system are it costs too much, and it's too just dysfunctional in all its aspects, public, private, and copays, and who's covered and all that other stuff, and uninsured.
But if Congress has to approve of these guidelines, there's only 15 doctors in the House of Representatives. What if someone says to you, I'm not comfortable with 420 people that know nothing about medicine making these decisions?
Yeah, well, you know that with the kind of Congress we have and our political system and 6 lobbyists on health care for every member of Congress, that there will be this huge dogfight, and this is a problem, actually taking the recommendations of this comparative effectiveness panel and acting on them. So it becomes all about money at some point.
Well, they actually have the way they're structured, the Payment Advisory Board sets a target for how much they want to spend, what percentage of GDP they want to spend, and how they'll get there in terms of reducing ineffective care and payment rates. They then propose that to Congress. Congress votes it up or down. They can't amend it. If they vote it down, then Congress has to come up with the same amount of cuts. And so there's a strong impetus to Congress to accept what the experts are recommending to them. We've used this method to close military bases for about 25 years because it used to be nobody would let the base in their district be closed. And so he never could close a base. So they set up the Base Advisory Closing Commission, and they make a list of bases that are going to be closed and send it to Congress. And if Congress disapproves it, then Congress has to close the bases itself. Congress does not like hot potatoes. And so I have little doubt it will be very controversial initially, but I think after a period of time, Congress is going to roll over and let the advisory board, as they do in every other country, make these decisions and these recommendations. And unless the board goes off the reservation and does something crazy, then their proposals are likely to be accepted. That's what we can hope. I do want to mention one more thing. I can't tell you how important it is that the ACA reforms our insurance industry, which was a terrible mess. One of the things it does is it limits the pay of insurance CEOs to $500,000 a year. I know they're going to struggle for their $500,000, but what are you going to do? You got to cut somewhere. So they can only get $500,000 and have it tax deductible. And then on top of that, if their administrative costs are too high and their profits are too high, then they have to make a rebate to their beneficiaries. Our administrative costs, which includes profit, are, depending on the estimate, between 25% and 40% of every dollar you give them. The Medicare manages to do the same thing for 5% or less. Even Medicaid, which is a program for poor people, much more expensive to manage because of the variety of populations in that program. They do it for 8%, but private insurance does it for 25 to 40%. Well, that's out the window now. They can't spend more than 15% if they're a large insurance company or 20% if they're a small one. That's going to mean they've got to get more efficient. There was a scandal a few years ago, as there is periodically, when somebody took a hidden camera to a golf course in Nevada and watched all these fat cat insurance guys having a pretty good time with good-looking women and big bottles of champagne and et cetera. And so and they can't do that anymore because they'll have to give the money back to the insured people.
Do you understand those figures? I mean, the overhead that these health insurers are griping about is not to exceed 20%. And a bunch of these big insurers are asking for waivers so they can have 40% overhead. Now, the overhead is all administrative costs, but also marketing and profit and CEO salaries and so on. And here's Medicare with a 3% overhead.
There is one other thing about the ACA that's actually good, and that is the mandate, and you heard about that from CNN. And what the mandate begins to do is to require everybody to have insurance. And so it's a very early, not adequate or sufficient, but an effort to control some of the costs in the system and the cost shifting. So that, for example, about 10 years ago, Florida repealed its motorcycle helmet law. So if you are over age 21, and many of you are, you may lawfully drive your motorcycle at excessive speeds and allow the wind to rush through your hair. And allows us to resuscitate you in the emergency room at roughly $100,000 a day to be paid for by your fellow Floridians. And so if everybody has health insurance, and amazingly people who own motorcycles and don't wear helmets seem to own it less often than other people, then we begin to make the system a little bit more equitably affordable for everyone. But more needs to happen there.
These ideas, the insurance exchanges, that's a competition. That's a Republican idea, having all these different insurers compete. That's free market. That's a Republican idea. Okay, the mandate, that's a Republican idea. The idea that everybody should be accountable and have insurance, that's a Republican idea.
Which Republicans? Can you name elected officials?
Well, most of them came out of the Heritage Foundation.
Okay.
Yeah.
John McCain, though, is one of the ones that...
McCain ran for president on taking away, on the individual mandate and taking away the insurance deductibility of of premiums, the tax deductibility of insurance premiums.
And now just 4 years later.
As some conservative pointed out on Sunday in the New York Times, the real reason that the Republican Party opposes the ACA reform is Obama.
Well, I'm not sure where in the program this fits. I just want to say that while the ACA is a terrific product and it has a number of weaknesses, but it's a terrific reform.
And we will,
but
I am going to ask you about the
it's
weaknesses.
not really the point I want to make. The point I want to make is that both parties are guilty of using health reform every time as a whipping boy. And they use it because it's a good way to define one party versus the other. And so, for example, Richard Nixon proposed a national health insurance plan that was probably a little more liberal than the ACA. And the Democrats ran him out of town on that. So health policy is uniquely ideological. It's a good thing to use to beat up the other party. And so no matter what idea you offer, the other party hates it. And it doesn't matter that they offered the same one last year. And it's just endemic because it's an easy thing to yell about.
Good point.
So there were two big things that I want to have you discuss from last night's debate, and both of them have to do with Medicare. The first is this claim that the ACA has taken $700 billion away from Medicare, and the other one is this idea that Obama is saying, which, I mean, it's Mitt Romney's idea, but that's the voucher system, and why that might be good and why that might be bad. Before we get to those two topics, though, I want to show the audience, it's about 15 seconds. No, it's not. It's like 2 minutes. It's a portion of Paul Ryan's acceptance speech from the Republican National Convention, and he's saying many of the same things that Mitt Romney said last night in the debate. So we're going to do that now.
And the biggest, coldest power play of all in Obamacare came at the expense of the elderly. You see, even with all the hidden taxes to pay for the health care takeover, even with the new law and new taxes on nearly 1 million small businesses, the planners in Washington still didn't have enough money. They needed more. They needed hundreds of billions more. So they just took it all away from Medicare. $716 billion funneled out of Medicare by President Obama. An obligation we have to our parents and grandparents is being sacrificed, all to pay for a new entitlement we didn't even ask for. The greatest threat to Medicare is Obamacare, and we're going to stop it.
Dr. Bellamy, when I met with you to prepare for today, you explained to me where he gets this $700 billion claim. Can you explain to the audience?
I'll try. It's a two-part thing. $716 billion. There are in Medicare, the Republicans back with one of the Bushes when they were in control said, let's privatize Medicare and make some HMOs under private control compete with traditional Medicare. And they called them Medicare Advantage plans. And then, when this thing got underway, the same privatization Medicare group came back and said, this is more costly than we thought. We need extra money. And Congress gave them about a 13% additional amount of money above traditional Medicare to run those Medicare Advantage plans, 13%. Now, the studies have generally shown that the Medicare Advantage plans don't do it any better in terms of outcomes health-wise than traditional Medicare. But they've been getting this 13% extra. And so the Obamacare tries to take about half of that 13% and kind of try to phase some of that out and use that money for some of the subsidies they're going to have under Obamacare. There is additionally a few $100 billion out of providers, primarily hospitals, as I understand, that the hospitals agreed to with the kind of understanding that they would have fewer uninsured people under Obamacare. And so they agreed to these other cuts. And the total comes to about $716 billion. Now, this same Ryan guy has exactly the same cuts in his proposed budget plan. But he criticized Obamacare.
Yeah, I think it's worth noting that the Congressional Budget Office, and they're sort of the budget referees of Congress. They're nonpartisan, and they're the final arbiter of whether numbers are real or not. They have concluded that the Affordable Care Act over its first decade will actually be a budget deficit reducing tool, that it will reduce the federal deficit by very close to $1 trillion. $924 billion is the number they come up with. Now, there's a little asterisk that needs to come with that. These things are very, very complex to actually calculate, and they probably get it right about half the time. Sometimes they estimate it, as too high a savings, sometimes too little. Sometimes they call a savings when it's actually should be a deficit. But nonetheless, they're the referees, and they think this will save money. So, what you're hearing from Dr. Bellamy is that there's no reduction in service in Medicare as a result. And in fact, there are new preventive services that are made available to Medicare recipients, plus that closure of the donut hole I mentioned later. So in all probability, a Medicare recipient is actually better off. And so when you see, people in New Hampshire and elsewhere, parading with signs, "Don't let the government touch my Medicare," they're a little confused.
I'm a big fan of the CBO, and I tend to believe their figures, but I would just caution you, everybody's fallible, and the CBO health estimates are mostly done by a guy who was my student at University of Michigan who didn't finish his PhD. Ooh. So, moving right along.
Dr. Weissman, if I asked you how often the CBO is right with their budget estimates, what would you say?
How often?
How often?
I would say that they are, their validity is so well recognized that it's not usually challenged. Let me put it that way. I think most Congress people, senators, believe them and take their word as gospel. And Congress passed a law that says they basically have to take it as their. So I would say they're right most of the time. But they work under some constraints. Like, for example, even if they think something's not going to happen, if the law says it is, they have to believe that. They have to act as if it will happen. They don't get to say, well, we don't believe that. So those are, but generally, I would say I believe them.
So I really want to try to investigate some of the negative aspects of the ACA, some of the bad things about it. If Mitt Romney's campaign is going to say the things that they're saying, we owe it to listen and to see what's true. So the last two video clips I want to show you today are from the Heritage Foundation. Heritage Foundation is a conservative think tank. No one's hiding that. They definitely have partisan motives to get Republicans elected. Now you'll notice that these two videos are not directly from Barack Obama or from Mitt Romney. I had a video I was going to show you that was directly from the Obama camp, but because of time I cut that. But I want you to know that, and feel free to correct me if you find something else, there's very little in Mitt Romney's official website or his YouTube site that really lays out his official criticisms of Obamacare. So we've gone to other sources, and the Heritage Foundation is one of them. So these two clips I think, bring up some legitimate concerns, and then we'll ask the panel if they really are legitimate.
You might have heard that the new healthcare law will save money and increase coverage. But that's only because the costs, restrictions, and cutbacks are hidden away, years down the road where legislators hope you won't notice. Some of them might seem silly, but fast forward, and you'll find reductions in healthcare options for seniors and the disabled, and significant tax penalties on some existing healthcare arrangements. You can technically still keep your coverage as Obama promised if it's approved by the government and meets requirements that haven't been written yet, and only if new federal mandates and taxes don't put your provider out of business. Starting in 2012, payment reductions to popular Medicare Advantage plans will commence, forcing seniors out of plans that give them a broad choice of plans and benefits. Then the new taxes will hit hard. Some of them will restrict your choices, while others will be passed down as higher costs to you. In 4 years, the government will tell you what kind of health insurance to buy and will fine you if you don't purchase it. New mandates and penalties on businesses will discourage hiring and stunt economic growth. Even if an employer already offers coverage, the employer will be fined $3,000 for each employee who chooses to receive federal subsidies for insurance. This will discourage businesses from hiring low-wage workers who need jobs, putting the very people Obamacare was designed to protect out on the street. While new costs to the taxpayers rise, the power of individuals to control their own care, dollars, and decisions will decline rapidly. Other taxes designed to penalize generous Cadillac insurance plans will eventually hit more and more working families. By the time the law goes fully into effect, new taxes and higher healthcare costs will suffocate you, and your power over your own coverage will flatline. But as long as everything looks good right now, who cares?
How long have you been in this office?
I've been in this office 12 years. I was the first doctor to come into this building. The frustrating part of my day is I have 2 employees that work nearly full-time fighting Medicare and other insurance carriers for work that I have done. I absolutely detest that part of my life. I never imagined that I would do work and then have to fight a third party to get paid for the work that I do. So that part is particularly miserable. We're also being portrayed very poorly by the media, or we have been in the past. And now we have to fight the government. I mean, I never imagined that I would have to become politically active to take good care of my patients. And so that's added a whole nother element to the life of being a doctor. I took Medicaid until about 4 years ago. Medicaid paid none of their bills in my office for 18 months. And every single registered letter that we sent them came back saying that they had had problems with their computer, and that was why they could not pay my bills. So at the 18th month, I gave up and said, we can't do this anymore. Their reimbursement, as I mentioned earlier, is so low that I would have to see nearly 20 patients an hour to make any kind of reasonable reimbursement on it. In our community, with decreasing reimbursement, many of the primary care physicians have gotten off of Medicare. I don't actually know anyone who is taking Medicaid. Medicaid in Georgia reimburses about $30 for an office visit, and my overhead cost about $350 an hour before I take a penny out the door. So we would be looking at trying to see 20 patients an hour if we took Medicaid. So because so many physicians are getting off of these insurances, it's very hard to find places to send the patients. So a lot of our Medicare patients are having to go to the emergency room. I feel a great deal of anger. And when I look outside of myself and I look at the rest of the country, I'm very worried about the country. If a person who has $350,000 worth of education and 17 diplomas can't afford a 1,500 square foot office, what does that tell the young people in our country about education? I mean, when I was growing up, we believed that if you really worked hard and got a great education, that you would have a really good life in America. And I think what I'm experiencing personally is happening all over America. And I really worry for my young stepdaughters, because I don't know that I'll be able to tell them, work hard and get a great education. You know, this is America, you're going to be prosperous. I'm concerned about the bigger picture, not just myself.
Why do you continue to practice, given all that's happened in the last year to your profession?
I love it. I love being a urologist. I stayed in school until I was 32 years old. Also, every day when I get in my car and go home, I can think of at least 5 to 10 people that I have really helped, and so many people don't get that out of their job. So I will probably continue to try to do it until it's no longer economically feasible.
So both of those videos throw a lot at you, especially the first one with all those numbers. Frankly, couldn't keep track of all of them, and that's probably the 10th time I've seen that video. But one concern, I think, is the overriding message is some of the costs of ACA down the road that we may not be prepared for. Can any of you comment on that?
10% tax on tanning booths. I got hung up on that one. Not really. This lady makes some good points, for instance, Medicaid reimbursement is traditionally kind of low, and a lot of physicians in this town whom I trust have told me they lose money treating Medicaid patients. But
just so we understand, ACA expands coverage to people that currently don't have health insurance by expanding eligibility to Medicaid. So that's the concern, right?
But for the first 3 years of the ACA reform, they recognize this problem, and Medicaid reimbursement will be increased to Medicare levels for the first 3 years. Now, that is a problem in that what happens after 3 years when we either add more money into the system to continue that, or we suddenly have a bunch of folks who had Medicaid and now can't get a doctor. You know, so there. You asked for problems with the ACA reforms. There are a bunch there.
Well, let me pick up on that. I mentioned earlier opportunity costs, and so we spend somewhere around the neighborhood $2.5, $2.6 trillion a year on health in the U.S. We don't get great value for that money, but that's a big chunk of money. It's almost as much as Dr. Weissert's current salary. So I mean, we know we're getting that. We could pay more, but we also spend a whole lot more on things that enable us to blow up other countries. We're something like, if you added up everybody's defense budget for the next 27 countries, they don't add up what we spend. So we're making decisions all the time about how we're going to spend our money. And those are opportunity costs largely, and there are a lot of things we could spend money on. Now, in the last decade or so, actually a little bit longer than that, every state budget, so the 50 states, that's for all of you, there's still 50 states, just as many as when I was in school. Well, almost as many. It used to be education was their #1 budget issue. Now for many of those states, it's Medicaid. It's either Medicaid or education, so it's a big share of their costs. Many of the states that have elected as a result of the Supreme Court case, they say they're not going to opt in for the Medicaid expansion that's part of ACA. And most of those states are southern states. And the big concern they have is less, or their alleged concern, is less about their match under the, with the Affordable Care Act, but rather if, in Florida there's probably about 1 million people who are eligible who aren't currently enrolled. And so they would still have to be covered using state dollars, for example. And that is a potential budget issue. But if you're the governor, for example, in Florida, of all the people living in Florida, you might think you would want them to have health insurance, or the governor of Texas or Louisiana. So, I don't think it's necessarily a fair model. The opposite of, what Romney is proposing is to give block grants to the states. So here's this chunk of money. State, you design what your Medicaid program would look like. And that has more budgetary control for the state, but it's likely to lead to 50 very different programs with very different packages. And southern states have tended to opt for very low-cost Medicaid programs that have paid practitioners very poorly.
Well, I want to comment on the second film. First of all, the woman conflates all the time Medicare, which is a program for elderly and disabled people and pays pretty close to private pay rates. 94% of physicians accept Medicare patients because they pay pretty well. She conflates that with private insurance. She said she has 2 people working on Medicaid and other insurance. Well, it's the other insurance that's given her a problem. Every insurance company has its own form. Every insurance company has its own list of things they cover, drugs they cover, procedures they cover, different rates of payment. No wonder she's got 2 people. If she had only Medicare, and I could probably get Ray to come out of his chair here if I proposed to him that most countries use a universal system of care. They have one payer, and it's the government, and that gets rid of all those problems that she's listing. Now, so that was the first. The second thing is she says her overhead is $350 an hour. That's what, $1.5 million a year, right? For her overhead.
1,500 square feet of office space.
Yeah, so what is she, in Malibu, for God's sake?
She's in Atlanta.
She got a beach underneath her? What is that? That's ludicrous. But I don't want to get too technical here, but she says she can't afford to take Medicaid patients because it costs her money. The economics of Medicaid is you take all the private pay patients you can find and you beg them to come. And if you can't fill up your practice with private pay patients, you have 2 choices. You can either move to a more expensive office to attract more patients, because now you got a nicer looking place, better looking nurses, you spend more time with them. So you can either spend more money to attract more private pay patients, or you can fill up the unfilled part of your day with Medicaid patients. They don't pay as much, but you don't have to spend anything to get them because they're standing out there waiting to be served. So the economics of it is Medicaid patients basically take the slots available. Now, do you think those slots are available in a practice that pays $1.5 million a year for 1,500 square feet? She's never going to take a Medicaid patient. She wouldn't take one if it was her mother. I mean, it's just ludicrous. They're not going to go there. They go to the poor part of town where the rents are lower and the physicians are making less money. So it was a little distorting.
Disingenuous.
Yeah, I mean, it was disingenuous is a good way to put it.
I agree with what both these people said. To me, now you asked for criticisms of the ACA reform. I've got plenty. The 2 biggest the 3 biggest are that it increases our already huge burden of administrative overhead. There are over 5,000 private insurers, each with different rules. And now you've got this ACA reform, which they have different rules for an employer with 25 to 50 employees, 50 to 75, 75 to 100. Now this is some kind of imaginary universe because people don't finish high school and go to work for some company and work there the rest of their life. They keep switching companies back and forth. Some are part-time, some are OPS or whatever, some are working out of their home, and the keeping track of all this from month to month is just going to be phenomenal in cost. And they're just the complexity and the added administrative waste in the ACA reform is a terrible addition to the system as far as I'm concerned. Now, it used to be, we said 31% overhead before the ACA reforms. I think it's going to be 35% now. All right. We still would have 27 million people uninsured. And the ACA reform has not been strong on cost control. They have some little areas where they try to control costs, but in general, they haven't done a very good job of controlling costs. And so those are the big issues I have with the ACA reform.
So I would agree with those completely. And so just to put numbers there, so we've got this runaway cost of health care. If we were looking for how we would reduce that administrative burden, of all those forms in Canada, for example, instead of having 2 full-time employees sort that out, someone would work on that for a couple hours and submit the bills to the Canadian government, and they'd be done and they'd be paid. And so the overhead would go from roughly a third down to just a couple of percent. And when you think about that overhead, if you reduced a third of the overhead, you're talking about something in north of $800 billion. That's real money. That there's a lot of things you can buy with $800 billion.
We should stop and let people ask questions.
I think you're right. Can I just get the three of you to give closing thoughts on healthcare policy and the election, what you think people shouldn't forget, and then we'll get to questions from the audience.
Well, I think the most important thing to realize is that what Ryan and Romney have proposed cannot work. They've basically said they want to keep the good parts of Obamacare, the coverage of pre-existing conditions, for example, and no lifetime limits and a few other things, but they want to get rid of the mandate. The basic problem is if you don't make everybody buy insurance, the only people who buy it are the ones who are going to get sick, who know they're going to get sick. And so well people don't buy it. And that means the system crashes because it doesn't have those dollars coming in from people in their well years when they're going to need care later in their sick years. It cannot work. And that's why Governor Romney put up the individual mandate in Massachusetts, because you can't do it without that. And now he's running against that, saying he's going to keep the good parts and throw that out. Can't be done.
Yeah, I agree with that, and I would say that an analysis of what the ACA reform would do, reduce from 50 million uninsured to 27 million uninsured, but Romney Care, eliminating the ACA reforms, the number of uninsured would soar to 72 million. So, anyway, I agree.
The only thing that I would add is, pretty much we have a long history in our country of not having health care policy, which makes it a great topic to teach because you can make up whatever you want. There is no policy. It's by default. And this was a noble effort into the Affordable Care Act to try and pull some things together, but it's hardly the end game. We tend to make health policy, to the extent that we do, by what would be called fragmented incrementalism, fits and starts, pieces of legislation that over time we cobble together into something that looks like a makeshift sort of blanket, that can hopefully cover people. So it makes no sense to roll back what we've just accomplished under the Affordable Care Act. It's a platform for future expansion to try and deal with some of the issues that we've talked about. There are better vehicles out there. All of us feel like universal payment and a system that covers everybody would simplify it and be more recognized about it. That's what developed nations do. But we're going to get there incrementally. If we look at rolling back the ACA, we're going back. We can go back to Teddy Roosevelt years, and it's just we're not going to go backwards. We shouldn't go backwards, and it would be the wrong thing to do.
Thank you. At this point, now I want to open it up to the audience. Any questions you have can be for one panelist in specific, could be about what you heard, could be about something you heard from the debate last night. Questions in general.
On Twitter yesterday, with the debate, I kept myself updated, and a lot of the comments were based on, well, with the mandate, my money and my tax dollars are going to pay for the sick person's medical bills. Why I was saying that, and what does that mean? And if it's true, what does that mean?
Well, it is true. It is true Here's what's been lost in this whole campaign. If we look at the larger part of the campaign, and it's about who should pay for what. You know, we're all citizens and residents of one country. And what's peculiar about Americans is we think we actually are a nation of 310 individual nations. You know, it doesn't work that way. We are, Gandhi said, interdependence should be as valued as independence. We fail to understand the notion of interdependence. And so when someone else in the country, you know, spends more on healthcare, if all of us aren't participating in that, we lower the health of the entire nation. And that's what we've been doing, you know, over the last 30 years. And so we should all be participating in a communitarian sort of way, which is we should all pay for it.
Well, another way to think about it is, I'm going to assume that you're well right now. You don't have any serious problems. What's going to happen to you in 10 years? You don't know. I mean, you could get hit by a truck and be left a paraplegic. You could contract a flu or get shot with one of these steroids and get an infectious disease. So any number of foodborne illnesses could happen. Any of those things could happen. So if we allow you to wait until you're sick to buy your insurance, the only people paying in are sick people. The system is set up because of uncertainty. Everybody pays, and when that some small percentage gets sick, that's where the money goes. In fact, about 75%, no, it's actually 83% of all of the money in healthcare is spent on about 20% of the population, because most people are not expensive. Half of the people in Medicare don't spend any money at all every year. But 1% spends, I think it's like 24% of the dough. So the only way that works is if everybody's paying in, somebody gets sick, they get their bills paid. The ones who are not sick, everybody pays the same.
And the trick is that 1% that spends 24% of it isn't the same 1% the next year. And you could be that 1% another year. Jump in there.
Well, the reason they won't be the same next year is they're going to probably die. Because, you know, that's where all the, I mean, a large portion of the money in Medicare is spent.
Yeah, the other weakness of the ACA is it doesn't have any death panels. We ought to be shooting old people because they're just, you know, where they get, I'm an old person. But I mean, it's just crazy. We're spending 30% of our healthcare spending goes on people in the last 2 years of life. And they die anyway. So, but, well.
Other questions?
So why do you think that it's going to be a more incremental change towards like a universal healthcare system if we already see countries that are prosperous right now? Why is it going to take us so much more?
Let me give you a quote, and maybe my colleagues will respond to it. You know, Winston Churchill, you know, the famous English statesman who, of course, had an American mother, said that, you know, Americans always do the right thing after they've tried everything else. And so we're going to continue to try to do every other thing before we eventually do what everyone else has found works and is the only possibility that can work. But we're going to test those out first.
I think we'll eventually get there because of what this female physician talked about. It's the burden of filling out all those forms. I think that's eventually going to push physicians to be less resistant to a single payer system, or at least an all payer system, which gets pretty close to a single payer system.
Over half of our employees at the clinic where I work, Tallahassee Orthopedic Clinic, over half of the employees are just dealing with insurers, trying to get tests authorized by insurers, arguing over payment. You know, they could be replaced. Well, anyway.
But if you have a universal healthcare system, wouldn't that decrease the amount of paperwork you have?
Absolutely. Oh yeah, Medicare is a universal health. It's a single payer system, and it's much easier to deal with than this stuff.
So if it's the physicians that are complaining about having too much paperwork.
Well, the insurance industry would not like to be replaced either.
Right.
Okay, and the hospitals, everybody everybody is making out in the current system, and so they don't like to see change come along that might cost them money. And unfortunately, they give a lot of money to Congress when they're running for office. The health industry is always a leading contributor to campaigns.
And one other factor here for physician opposition is that there's this feeling that, well, if I don't like the reimbursement rate that this insurer is going to give me for doing an appendectomy, I've got somebody else over here, maybe I can get them to do better. But if you've only got one payer, a single payer system, that's what you're going to get. And that's frightening to physicians.
My question is in regards to the pay of people in the health profession fields. How will universal health care affect it? Will it decrease the pay? Because I have many friends who are going into pre-med, pre-dental, physical therapy, and they are afraid that their pay cut is going to take a tremendous hit. I was just curious on your opinion of that.
I think they're going to take a tremendous hit even under the current system, because insurers are well, first of all, private companies who provide most of our insurance, about 60% of the insurance is given by your employer, they're getting out of the business. More and more firms are announcing they're going to go to a defined benefit, a defined contribution. They'll give you this much money, go buy it on your own. And as that happens, it's going to push insurance companies to push costs down. And as they push costs down, they're going to push down on what they'll pay physicians and hospitals and others. And as we see more physicians going on to salary, so that they bear fewer of these office expenses, I think they're going to make less money. But we already pay our physicians more than any other country.
I totally agree.
What do you think, Les?
No, I agree with Bill, but there are a lot of disparities here. And, Bill said something very early. About 30% of American physicians are in a primary care area of practice. Around the rest of the planet, that looks usually around 60% in countries that have better health outcomes overall, greater life expectancies, lower costs. And that's a direction we should be going. But primary care specialty physicians make on average a little less than half of what specialty physicians make. And I think there's a lot of room for moving towards more primary care and actually paying primary care physicians a little bit better and still overall having a net reduction in pay. But physician salaries are only about 15% of the overall healthcare costs right now. So it's things like pharmaceuticals, hospitalizations, and again, our lack of wellness as a society. I mean, we are the heaviest nation on earth per square meter. So, in fact, most of us take up more than a square meter. We've got to lose weight, we've got to exercise more, we've got to reduce costs by being healthier. But no health professional is going to starve over the next several decades.
I've thought about putting in a Mercedes tax. That might do it. This young lady had a question.
Yeah.
So if Obama's current plan, the Obamacare doesn't get repealed,
We need to repeat those questions because they can't
and obviously everyone's going to have health care. But there's a vast majority of people in this country that are illegals. We have a lot of Mexicans coming in, and they're currently using the healthcare system because they're not going to have to pay that healthcare. They're not going to be under that law to be forced to buy the healthcare. So how is that going to affect the plan? And who's going to be paying for that at this point?
Well, there are two provisions.
Dr. Weiser, can you just repeat her question for the audience?
Oh, she asked who's going to pay for the cost of illegals because they don't pay into the system. They will continue to be an uninsured group. But when they get sick, they go to the emergency room. The emergency room operates under something called EMTALA. It's a law that was passed because some hospital in Chicago refused to accept a woman who was in labor and sent her to another hospital. She had the baby in the taxi. And so Congress passed a law in 1986 that said, if you've got someone who shows up in your emergency room, you have to first stabilize them and treat them, and then you ask them if they can pay. It used to be, I can remember going to the hospital and holding my arm up, which was bleeding like crazy, while I sat at a typewriter, and the woman filled out the form, which took like an hour. And that was typical. But now you walk in, they treat you, they don't charge. Illegals can do that. They can't come back and have the stitches taken out, but they can sure have them put in. And that's going to go into the hospital's bad debt, and then somebody's got to pay it. Either the rest of us who are insured or the county if it's a county hospital. So that's one. If they are in an emergency situation, Medicaid will pay if it's a true emergency. Medicaid will pay for that, but not for any kind of follow-up care. But it's a flaw in our system. In the United Kingdom, even if you're a tourist, they pay for you. But everybody pays because they pay for it out of taxes. It's a hole in the system. There's no effort at fixing it.
Yes, well, they do actually pay into the system, and that's poorly understood because most of them are employed, and so they're undocumented residents. They pay taxes, they pay Medicare taxes. They actually do contribute to the system. I'm not sure what the net outcome is, but we're looking at roughly about 11 million people who would be left out that fall into that category. So in a country of 310 or so million people, that's still a significant number, but it's not as big it's not as so-called big a deficit as people think.
This gets all political. When we talk about universal health care and propose covering everybody like they do in these other developed countries, some politician will say, well, these sick people needing kidney transplants are going to be, swimming across the Rio Grande to get here and get their kidney transplant here in the United States, and it just, everything kind of goes south.
If you can swim across the Rio Grande, you don't need a kidney transplant, I think is what he's saying. Yeah.
Well, isn't it kind of shallow? You don't have to swim.
If you can walk across Review.
Any other questions? Yeah.
How enforceable is the individual mandate? Because it's like the penalty is only $2,000 versus like $5,000 cost for basic insurance. So
you've hit on one of the key flaws in the ACA. It was initially going to be considerably higher, 9 or 10% of income. Now it's low enough that you're going to have a considerable amount, I think, of noncompliance. And it's very difficult to figure out how you're going to induce those people to buy, since we don't have debtors' prison. So I don't know how we're going to do that. I think they're going to continue. They're in this estimate of remaining uninsured. It's a flaw.
In Massachusetts, I think the first couple of years, about 800 people chose to pay the fine rather than purchase insurance, and they showed that they would kind of go without insurance for a while, pay the fine, and then when they got sick, then they would get back in, which is what it's supposed to prevent. In reference to your question about physician incomes, part of our problem here, your friends in medical school are running up huge educational bills. And the average for FSU College of Medicine students, they graduate with an average of $145,000 debt. And it's higher in most other schools than it is here. In many of these other countries that have universal health care, they pay for your medical education. Right. And that makes a big difference on whether people choose primary care, and their debt load when they graduate. I mean, it makes a big difference in lots of ways. Now in Canada, which has a single payer system and pretty much covers everybody, the physicians earn about 15% less than U.S. physicians do.
So for those of us, because I'm headed to physical therapy school, so for those of us who are going to go through that debt, my debt's probably going to be between 100 and 150, depending on where I go, where I live. So for me, would I end up in a bad situation if this does fall through, or is this something that I might not have to worry about, or is it something I should think about as where I'm going?
You're going to have lots to worry about.
Will I be able to pay my debt back in a reasonable amount of time? I'm content with it. I've come to terms with my debt, but I don't want it to take 50 years to pay off. So that's my main concern. And I mean, I'm pro Obamacare and all that,
Yeah, I mean, I think this is a troubling, aspect, and I went to a lot of schools and owed like $5,000 after I was done, and the Air Force was kind enough to pay my way through medical school, and those opportunities are not available to everybody, these days, and the first things people lose sight, and I think that urologist up there, kind of made me unhappy for a variety of reasons. You go to medical school because you have a passion about helping people who are less fortunate than you, who have poor health, and then you later find out medicine is a business and you don't like how those numbers line up. You may not be in the right business, and I'm not suggesting that about you, but I am suggesting it about people who are having those kinds of misgivings. But go to law school. It's a great place. Go to business school. But we need to look at ways to control the cost for you and to have low-cost loans. I do think if we really get to a universal payment system, we need something that we used to have in Florida called the Florida Medical Health Service Corps, which is, in exchange for working in an underserved area. There's a national version of this. We would pay your loans, and so there were give-back options. But I think if we go to some kind of controlled cost, that, like in European countries, that you buy your books, but the tuition is covered. You're responsible for your housing. So I think you're in that kind of sandwich or window period where it's going to be a little bit less clear. So yeah, but I can tell you right now, from the Harvard Law School class of 1988, and I won't tell you how much I get paid, but I promise you I'm in the bottom 10% of what my classmates make, one of whom is Michelle Obama. So there you go.
The ACA actually expands the National Health Service Corps, offers a whole bunch of new slots. But while you're thinking about your friends who are going to be relatively well off, probably for the next 100 years, keep in mind that healthcare costs are the leading cause of bankruptcy. So for the poor Slav who's working on the line, these out of control healthcare costs are really a burden. I mean, it's one thing to have a debt. It's another thing to have to go through bankruptcy because you went to the hospital, couldn't pay the copay.
But student debt is going to challenge that, I think. I mean, the over $1 trillion in student debt, I'm talking about all fields, not just medicine, that's going to be a cause for bankruptcy too.
So they might have to cut our salaries.
They may. Or I'm going to go back and be a lawyer then. There's one thing you all need to know about healthcare costs too, and that is roughly since about 1970, U.S. wages haven't actually gone up. The healthcare costs and inflation have completely eliminated any gain in wages since about the beginning of the 1970s. So it's been in the form of increased benefits. That increased benefit has been the same health package you had. So we're all paying for this, we're just not getting it. So that's the change that we might see, over the next decade with the Affordable Care Act and incremental change.
So we're right at 5:30. I'm so glad that you guys are here. Please join me in thanking our panelists. Don't forget that this is just the first in a series of events. Thank you so much for being here. I hope you had a good time. We'll see you at the next event.